Physician as leader says, I've got to learn to listen. I've got to learn to be a part of this conversation. I don't have to have a business degree and an IT degree. I don't have to have all these extra degrees. God knows I've got enough education and brain power. I don't have to add a bunch of degrees, but I really have to understand enough to be able to work with them and to be able to take a complex adaptive system, which is what healthcare is, and bring a lot of stakeholders to the table to listen to each other and learn together so that we end up finding better outcomes.
Welcome to the License to Lead podcast. I'm Patty Fay. This podcast is for physicians or anyone who thinks healthcare needs a transformation led by physicians. License to Lead means that physicians are charged with and must be in charge of guiding the vision and the culture of healthcare systems. Hi, everyone. Welcome to the License to Lead podcast. This is Patty Fay. My guest today is Dr. Jack Cochran, a plastic surgeon, national physician leader, and long-term friend. Dr. Cochran practiced plastic surgery in Denver, Colorado for over 25 years in private practice and at Kaiser Permanente. He served as the regional president of the Colorado Permanente Medical Group, and then he was selected to be the executive director and CEO of the Permanente Federation. So he was the national leader for Kaiser Permanente's 21,000 physicians in the care of 11 million patients. Jack's been named to the top 50 list of U.S. physician executives 3 times, and he has set the bar in so many realms as a leader in healthcare in quality and IT. And Jack even had a clear vision early in his career regarding the importance and real advantages of diversity in organizations and in leadership. He's passionate about equity for underserved populations, and he has had a hand in working alongside members of Congress and the White House in establishing meaningful quality initiatives in healthcare. Currently, he advises healthcare technology companies, he coaches CEOs, and he's a professional speaker and author. His latest book gets right to the point of the License to Lead podcast. Its title is Healer, Leader, Partner, Optimizing Physician Leadership to Transform Healthcare. And we are certainly going to talk about physician leadership and what that means to you, Jack. And I want to just give you a huge welcome to the podcast.
Thanks, Patty. So great to be here. Great to be doing this with you.
I think it's fantastic to finally connect. I've been trying to lasso you into this for a while.
We have a track record that's temporally exactly in sync. We started together. We sort of randomly got agitated and decided somebody had to step up and have a big fat opinion about certain things. And we just decided to do it. And there was not a well-worn path or a training module. We just sort of raised our hands and said, that's it. We're going to make some contributions here.
Yeah. I had forgotten about that, but you're right. We actually were in the same orientation class when we both joined Colorado Permanente Medical Group. And then we were on the board of directors at the same time. And we'll talk more about what happened after that when you became the executive medical director and then asked me to join your team before we launch into issues related to physician leadership. You grew up, you've characterized it as being in a house full of women.
The house full of women is a very interesting construct. I lived in that house for, until I was 18 years old. And I had these 2 sisters and a mom, and, they were very bright. They were very nice. And I didn't have this insight at the time, but all the tumblers in the lock for me just lined up. I was white, male, educated, straight, Christian, all the tumblers lined up that I sort of fit some paradigm that was kind of dominating at the time. Why do I say that? It doesn't mean that I didn't have to work hard to get into medicine, work hard to be a doctor, work hard in leadership. No, I did. But the tumblers all lined up. All I had to do was work hard. I didn't have to leapfrog or change paradigms or put up with a lot of headwind. And I think that is why I acknowledge and recognize vaguely and then over my life intensely what wonderfully bright people my 2 sisters and my mother were. And I think it also helped inform me as I got very interested in healthcare teams, nurses, et cetera, Because in my young days, nurses were mostly women. I got very interested in the nursing shortage. But when my mom and dad got sick and they had to go in the hospital, I was in practice. And I would go to the hospital. I wouldn't go every morning. I'd go a couple of mornings a week. I'd try to get there early so I could be there when the doctors made rounds. And I learned certain things that are so obvious, it's amazing that they actually required learning. But I would sit there in the mornings, and I realized on day 2 that 4 years of medical school, 6 years of surgery residency, 5 years of practicing surgery did nothing to prepare me to be the son of dying parents. I had no preparation to be the son of dying parents. So I sat in that room and I watched what happened. And I was only there for half an hour in the morning. The doctor would come in, and he or she were smart, kind, compassionate, understanding, good communicators, no issues with the physician at all. They were there about 7 minutes, and they did their best, and they explained what was going on. They took questions, and they were empathetic. They were great. But then I realized that my mom, the one that I really got focused on, because she died second, had another 23 hours and 53 minutes in that bed. And I sat there and I just thought, I'm that guy that just came in and then walked out, and I did my job, and I did a good job. But my mom laid there with her fear, her uncertainty, her anger, her pain, all these things for the rest of the day. And these angels started to come in, metaphorically, angels. And some were nurses, some were housekeepers, some were dietary. They were all healers. They weren't all clinicians, but they were all healers. So my mom and I and my sisters decided to create an award at Lutheran Medical Center in Denver for a member of the oncology healthcare team in honor of my mom and dad. My dad had already deceased, and my mom was unfortunately not doing well.
Wow.
And so we set that award up, and it was the Cochran Oncology Scholarship Award once a year now for 33 years. We've not missed a year. Anyway, then, as you know, I worked on the nursing shortage. We set up scholarships and programs. We set up a two nursing programs.
I love that. Yeah. I'm going to shift gears a little bit. A lot of folks who go into surgery and plastic surgery end up in cosmetic surgery. And I'm just wondering if you could talk about your interest in reconstructive surgery.
I actually did like cosmetic surgery. I did enjoy it. The problem is internally within the specialty, because of the way it's compensated, there is a pressure to go one way or the other in toto. In other words, it's very hard to have a balance. You're battling insurance companies, and you have to set your own office up around that kind of overhead and income, or you have a cosmetic practice. And so it wasn't that I didn't like it. It's just that I got to that crossroads and I made a decision. I was a surgical resident at Stanford, and I'm in a specialty. And at year 2, I go, I'm not sure I like this work. And at the university, they had this amazing professor of plastic surgery. He was this kind, gentle, wonderful, friendly, gregarious person who you just idolized. Because I was in the head and neck surgery world, we used to do a little work together, and I always used to sort of beg to scrub on some of their cases because they were so interesting. And they had this program of bringing children from Latin America and the Philippines over for these big reconstructions. And I used to get to do some of the work on the face that was in my specialty.
Because your specialty at that time was head and neck surgery. Is that right? Yeah.
Right. And I just fell in love with this reconstructive surgery. It was so interesting. I had a neighbor who was a plastics resident who had this one kid from the Philippines who needed about 6 operations, and he just moved him into his house for 2 years. And so we used to go out and play basketball, shoot hoops at the elementary school with this kid with all these different flaps and stuff. It normalized this kid's life so much, and his life was so abnormal. So I fell in love. I truly fell in love with plastic surgery. And so the guy there at Stanford, he says, I'll take you. But he says, the next opening in my program is in 3 years. So he says, but I'll tell you something. the guy I trained with, they both trained at Yale. And because he went into the Air Force, he hasn't had a long-term program. People don't know much about him, but he says he's the best surgeon I've ever worked with. And he was a kind of a rogue. He says, you'll like him. Wow. We just hit it off. And he said, absolutely. He says, you can get in year after next. So that's what happened. I became a plastic surgeon. And we had an international program, and we would go to Nicaragua and Ecuador and bring these kids in. And it was so intensely gratifying because I don't know how good I was, but I was obviously good enough to make these kids super happy. And that was amazing. So then I go to Denver in private practice with two wonderful human beings, two really great surgeons. But they were both very oriented toward doing more cosmetic surgery. And that was cool because I wanted to do the other stuff. And then you realize the euphemism of the 80s, managed care, which was really the insurance companies getting involved in the doctor-patient relationship with gatekeepers and nurse reviews and all this stuff, which was just, they were trying to manipulate doctors and patients. There was no managing care. So I was swimming upstream a little bit, trying to get approvals for a kid with a cleft, need a bone graft. And the insurance company would say, oh, sorry, Dr. Cochran, that's a cosmetic procedure. We don't cover that. And I was just enraged. I said, this is crazy. And at that same time, Kaiser, Colorado was internalizing tertiary care specialties. They were going to go after neuro and plastics. And they talked to me and I said, no, I was still doing some of their work, because they didn't have any plastic surgeons. And I love my two partners. And no. And they waited another year. We went to lunch again. They said, we really want you to come in and start our plastics program in Colorado. We are 23% of your practice. We're going to internalize with you or without you. It was one of those crossroads, another one. And so I went over to Kaiser Permanente and started their plastics program. And I started a plastics program at Kaiser, and I found to my great joy that it was a desirable place to recruit people, good people. And then comes Faye Cochran a little bit, because I had been there for about 5 or 6 years, and I was drinking the Kool-Aid, and I believed it was a great place, but I went, this place could be better if it was different. And I had this woman, Patty Fay, who ran for the board, and I had only just watched her bobbing along in the group, but I knew she had a voice, and I knew she had big opinions, and she didn't seem to be fearful of rendering those opinions. And she actually scared me a little because she was kind of bold.
What?
And then I listened to my colleagues react to her, and I thought, darn, that's pretty cool.
What do you mean? You've got to fill me in on this one.
You ran for the board before I did.
That's right. Yep.
A year before, and you got the highest number of votes ever recorded in the history of the board elections. Why do I know that? Because I got the second number. Because we did some training together, and I thought, man, she's got some chutzpah. She speaks up. And because Kaiser was a little bit of a polite culture, and we kind of all are kind of like woebegone, I thought there was a hunger there. And so I had some of my friends say, because, as you know, you ran for the board not because it was a fun thing to do. You ran for the board because meaningful issues had to be dealt with.
Yeah, I was either going to leave. I had come to that crossroads. It was follow wonderful doctors who had jumped ship and bail out, or get involved. And then if I couldn't make any change, couldn't help anything, then I could leave later. So you're absolutely right.
And then you and I on that board had 2 or 3 wondrous people who we hadn't necessarily worked with and didn't necessarily know. But when we came together around a sense of common mission, we had some real get up and go. And individually, we had some strength. Collectively, we had some influence. And so that changed everything. We had a man in the senior leadership team. His name was Bill Marsh, who I think was the best leader at that time I knew. I thought he was the best by far. And he and I and Victor and George, there was 4 or 5 of us that were selected to go to the executive leadership program at the University of North Carolina. At the same time that the group was getting ready to select a new executive medical director or CEO. Mm-hmm. And we get down to North Carolina the first night, and Bill comes up to me and he says, Jack, I want to spend some time talking to you about the EMD election. And I said, that is great. I am all in. I think you are by far the best candidate. He says, I'm in the perfect role. I'm doing the COO right now. He says, we need you. And I said, Bill, this is not false modesty. I said, Bill, come on. You're one of the reasons I'm staying is because I'm seeing you come in now with courage and values and substance. And you're a highly respected clinician. I learned that early on. That's got real cachet. So were you. I think I was too. Mm-hmm. I said, Bill, it's you. He says, nope. He says, Jack, I'd like to work for you. And it just stunned me. Just stunned me.
I think that was the start of a bit of a Jack tsunami. I mean, I think there were a lot of people tapping you on the shoulder, maybe giving you big nudges to consider the top leadership role.
And honestly, I am an ambitious person. We all are. Let's not get too falsely modest here. I would have never thought that, Pat. I thought the board was going to be a place I could really make some inroads and test. What you and I did was we tested our values because you were so good. You were so clear. This is what I believe in. What do you think? And people would go, wow. Or put me in the game, Patty. That is exactly what I've been waiting to hear.
Yeah.
The third year, when I was now a candidate, there was this cardiologist, and he stood up the night of the board elections, Larry Hergott. He was not a candidate. He didn't have his hat in the ring. He wasn't running.
Yeah.
And he stands up in front of several hundred people. And he says, I'm Larry Hergott. I'm from the Department of Cardiology. And I just want you to know that I'm announcing that I'm a candidate to run for the board tonight. And because of his stature, his gravitas as a human being, as a person, as a soul, people just went, Larry. And I remember his quote. He says, I'm convinced that the region and the group will survive. My concern is, will we survive with a soul? And talk about hearing a pin drop. And I thought, unbelievable presence and unbelievable spirit. And he got on the board and he says, I want you to run for EMD.
That's right. He had a mission.
I got Bill Marsh, Patty Fay, and Larry Hergott saying you ought to do this. It's over. Because these are people that I'll look to for their values, their courage. We had a bunch of people that were just right people, right time, coalescing. This is a bad use of words, but it was magical.
Even the controversy, all of the wrangling and people taking strong stands for their values and what they believed in. It was not easy, but it was a blast.
It also afforded me a platform to do things that I probably couldn't have done because you guys gave me such courage. And one of them was this notion that we should always support, care about, and be concerned with great physicians and support them in their careers, but we must only protect patients.
Right.
We can't support physicians if patients are being harmed by them. I said that a few times in the group and then nationally. And I had many people say, you got to protect doctors only. I said, I think the high calling is the patient, because as tough as it is to be a doctor, the role of patient is involuntary. Nobody wakes up in the morning and says, it's been a while. I haven't been a patient for a while. I think I can take a shot at that today. As hard as the career is for the physician and harder for some than others, the role of patient is involuntary. And patients trust nurses, and patients have relationships with lots of other people, but they don't trust anybody any more than physicians for clinical decision-making and clinical care.
And they trust that we have the power. That is what really lands for me, is patients trust that physicians have the power to help them and to take their part. And that's why it's so important, for physicians to make sure that we do retain our autonomy and authority to make decisions on behalf of patients, not to be tyrants, not to get anything for ourselves, but to make sure that we can fulfill our duties to patients.
You specifically taught me 3 words: physician as victim, which sits on the sidelines, wrings our hands, and frets over the fact that things aren't going the way we hope they should go. Physician is tyrant, who says, wait a minute, I'm in charge. I'm the big surgeon here. You're going to do things my way. Mm-hmm. Very disruptive cultural impact on that. And physician is leader, which says, I'm in the middle of this. And Patty, healthcare in this country is in the center of the American family. It is in the center of the American dream. It is in the center of the American family's dream. It is not the only thing there, but when you take a look at how healthcare impacts families physically, socially, psychologically, financially, people talk about the cost of healthcare and the finances, and that's real. But that same family works for a company or a government, and those entities take their budgets and they shift between health insurance premiums and salaries. So the financial impact on families is amazing. Many families ration healthcare at the kitchen table. Well, one of the adaptive behaviors of the cost of healthcare at the level of the American family is the coverage from the insurance. And we've gone from full coverage to partial coverage with co-insurance, co-payments. And the notion of co-insurance and co-payments, cost sharing, is really, it's a bet. Those families are making a bet. And they're betting that instead of a $1,200 a month premium, they can afford a $700 a month premium. They're going to put $6,000 at risk. So, average family sitting at home, they've got $6,000 that they don't want to spend, right? That's the savings, but it's in their deductible. Well, Johnny just had his 4th episode of tonsillitis. He's missing school. He needs to have his tonsils out. But the clutch just went out in my truck. So this month, I've got to get the clutch fixed. We'll get the tonsils done next month. Real families, not just real poor folks, but real families are making those decisions every day. And that's the American dream and the healthcare system. And so patients come out of the system physically, socially, psychologically, financially. And here we are as physicians, and we can take a multitude of points of view from that, right?
Yeah.
One is, darn, physician is victim. That's really too bad. Or physician is tyrant. Well, it's the government, it's the hospitals, it's the insurance companies, it's pharma, it's all that. Or it's just to say, we better be part of this. And we don't have the authority to change everything, and we don't have the right to be victims. We better figure out how to lead. And so that's where I say the sacred covenant of the profession is physician as healer. As healthcare has gotten more complex and more difficult, and it's required more teams and more IT and more finance inputs, that's where the role of leader comes in. You have to say, I'm not just abdicating all those other touch points for my patient and their family. I'm not going to control the finance people. I'm not going to control the IT people, but I'm going to say, I want to lean in and be part of that conversation. I'm going to find a place to be useful. And physician as partner says, sorry, healthcare team 1.0 was doctor, patient, and nurse. Healthcare team 2.0 was still doctor, patient, and nurse, but now we got specialists and clinical pharmacists and research and, QA and UM and all that. So we got another layer. It's not just us, IT, artificial intelligence, finance, government relations, all this stuff. And we say, no, they're on the 3rd floor. Leave them alone. Stop. Because guess what? They're coming to work every day working on healthcare. That's their job. Somebody hired them to work on healthcare. And we're going, they don't count? No. If we let them work independently, they're still going to do their job. They're still going to come up with solutions. But if we let them work independently, they won't have the gift of the touch and the trust that we have within the clinical space with patients. We're not going to be tyrants with them. We're going to be partners.
Jack, it's so critical. It's the physician who has put in their 15 or 20,000 hours on their steep on-ramp into the profession. And that's the knowledge of every nook and cranny of healthcare, the whole panoply of healthcare services, and physicians understand, or at least have been exposed to all these corners. So the amount of experience and academic learning and tacit knowledge that's accumulated, that's what we're depriving people of if we back up and say, oh, I would just like to see patients. I don't need no leadership role.
We are not more important, but we are disproportionately impactful.
Right.
Physician as leader says, I've got to learn to listen. I've got to learn to be a part of this conversation. I don't have to have a business degree and an IT degree. I don't have to have all these extra degrees. God knows I've got enough education and brain power. I don't have to add a bunch of degrees, but I really have to understand enough to be able to work with them and to be able to take a complex adaptive system, which is what healthcare is, and bring a lot of stakeholders to the table to listen to each other, and learn together so that we end up, finding better outcomes. We've got these two contrasts. We've got healthcare, which has got breakthroughs and miracles and amazing technology. And then we've got families that can't afford it, a problem with medical errors. Hard to say how big that problem is, but it's not trivial, as a backdrop against miracles and breakthroughs and cures. And then on the other side is the healthcare career. Mm-hmm. How do we take doctors, nurses, all these healthcare people who are doing the work that they dreamed of? Look at your own life and you say, when I was 20 years old, 21 years old, I applied to medical school and I had to write out a few paragraphs on why I wanted to be a doctor. That is a 21-year-old idealist. That is a highly energized, caring, compassionate, scientifically sophisticated healer. Fast forward 3 decades. How you doing, Jack? I'm burned out. I'm unhappy. I'm crabby. Well, there's another contrast. We've got the wonders of care and the problems with care access and predictability and quality. We got the wonderful ways for doctors to take all this technology and get better and better results, and burning out. We can't solve those problems in series. Those problems have to be solved at the same time. Yeah. And it's about leadership, and it's about clinicians leaning in and leaning forward. We've got this profession, which is an honorable profession. And some of us are doing okay and thriving and feeling pretty good. And some of our brothers and sisters are really hurting. We get certified, qualified, we do all these things, and then we get frustrated because we've still got the accountability, but we don't have the authority and the ability to influence everything, and no ability to lead or to be involved. The definition of burnout is having all the responsibility without having the authority and the ability to influence.
I love that statement.
You taught me that.
I know. It's the reason for the podcast.
We go to all this hard work getting into medical school, all this hard work getting through medical school, residency, night call, practicing, and we're getting beat up and frustrated. We've got to leave from where we are. The medical degree at one time was a vocational destination. You went to medical school to get your MD or your DO, you finished it, you became a doctor, you practiced it. It was a vocational destination. Today, it's a pluripotent professional preparation. Today, the medical degree provides you a tremendous grounding in the science, the knowledge, the issues, to be a contributor in a variety of ways. We started out on the periphery. We're moving to the C-suite, not as tyrants, but as compassionate caregivers and healers of the system and of everything in it. And so it's a pluripotent professional preparation is the possibility for the degree, including full-time doctor, honorable path, wonderful path, but not the only path, not the only path.
That's going to be a little audio clip. Let me tell you that. I love that. Pluripotent professional preparation.
The brain hasn't died, Patty. The brain hasn't died.
No shit, Sherlock. All right. So you talked about getting on the board of directors and moving really directly from that to being selected as the president and CEO of the medical group. But I know that you were tapped a few times prior to that. You were asked to take on a leadership role and you declined. And I wonder if you would speak to that.
Yeah. Don't lean your ladder up against the wrong wall.
Say more.
If you are asked to do a job, there is in our own fallible souls a tendency to be flattered. And then when the person who recruits you is giving you a little bit of the smoke, to say, well, wow, am I that good? Really, am I that good? Maybe I should do that. And yet, you have to realize that whatever that job is, it doesn't exist in isolation. There are people above you and below you. If below you, it is a wasteland because the culture has been destroyed. And if above you, there is not a eagerness to change culture and to take chances, you're not a divine entity. You can't just come in here and make miracles happen. So don't beat yourself to death. There are certain jobs you just need to say, no thanks, or not now, not now. So I think that that's true. And so much of this is about developing a culture. So I have learned something that I would have never said 20 years ago. Possibly one of the advantages to my early job success, and there was success, objective success, was my inexperience. I didn't come in all full of myself. It wasn't false humility. It was real honest to God humility, because I had this clinical career, which was kind of okay. You know, what wasn't so bad. And how did I get there? Well, undergraduate, working hard to get the grades to get into medical school, 4 years, 6 years of surgery residency, examination, certification, qualification, mentoring, monitoring. You know, that's quite a pathway. And then I parachute into the board of directors. I'm new here. How's the business run? I don't know. Next year, I'm selected president of a business entity, a medical group as a business entity. What training did I have for that? On the job, just in time, trial and error. That was my training. But you know, at least I knew it. I didn't have a sense of having to fake it. So that's why I think the inexperience and the naivete wasn't so bad.
Right.
And I went to the Stanford Business School for the summer program, and I did this listening tour. And one of the reasons I did it was I thought, I am a tertiary care specialist, and I actually had a pretty good life. I wasn't unhappy, and I was taking on a job where there was a lot of people that were not happy. I better not just say, oh, I know what's going on. They just need more FTE, or they need more this or that. I said, I better go out and listen. It was kind of remarkable, because 20 years later, I still hear people say to me, I remember when you came out and listened to us 20 years ago, as if it was some divine, magical piece of brilliance on my part. I just didn't have a sense of what I should prioritize.
It was unprecedented. That's the extraordinarily sad element here,
Right.
is for the leadership to come and listen was unprecedented.
And I took notes, and I saw everybody. It was 400 and 500 docs at the time. I saw them 4 or 5 at a time, every hour. I'd go to a clinic for like 3 or 4 hours every day, and I'd take notes. And by the time I got to about the 4th clinic, my notes were about a quarter of the page, because I had heard so many themes so often and so many times that I was finally starting to get it. I said, well, we've got to get more efficient. We've got to be more effective. We've got to do those things. And that became the second and third constant, right? You know, optimizing the care experience, streamlining the care process. That was number 2 and number 3. But number 1 never changed. Preservation and enhancement of career. My partner over in the health plan said, well, that is the most clear proof of your inexperience and your naivete I've ever heard. We are losing money. We are losing members. And you're out promising the doctors you're going to protect them. And I said, that is an interesting extrapolation from what I just said. I said preservation and enhancement of career. And by that, I meant honoring the professionalism. This is an honorable profession. We have people leaving to open bed and breakfasts. We have people leaving to go to the university. We have people depressed. And nobody even says, we appreciate the profession. And so, yeah, preservation and enhancement of career. Patty, it never changed. It hasn't changed in 20 years. Honor the profession. The key to leadership is listening, acknowledging what you heard, challenging it, repeating that process so that you begin with whomever you're working with to co-create understanding, to co-create knowledge, to co-create context, so that you can then together start to explore the co-creation of solutions.
Yeah, right. I love that. So, Jack, can you talk about the cultural change that you were able to lead? Were there a couple of things that you see as the most important ingredients in making the changes that you led?
Yes. Because of my inexperience, I could say, well, I want to do things differently. I want to go in a different direction. I want to behave differently myself. And I didn't realize a couple things about myself. I knew I was a decent listener. I didn't realize I could become a pretty good listener. I didn't realize I was courageous. And turns out I am somewhat courageous. And that was in no small part because I had tremendous team. I changed teams. None of the changes that I made was taking out a bad person and putting in a good person. They were me saying, I have got these new thoughts and new priorities. how do I create a structure on my team to make that work? And how do I find people to populate that structure? It was very intentional. Maybe I should have had an MBA. And I realized that because of how the elections went and how angry many people were, remember, the morale was at a very, very, very low point.
Right.
I couldn't come back and say, we've changed the sign on the door, everything else is the same, but it's going to be different. And I would have said to them, I didn't listen to you. When I was out there listening to you, I didn't listen. So I had to change people in our profession. They get to go be clinicians, which I think is the higher calling anyway. So I didn't feel terrible, although the moves weren't welcomed by everyone. I also went from an organizational construct where every vice president or president looked exactly like me to embracing the fact that the medical group, and certainly our patients, didn't all look exactly like me. I embraced diversity. At that time, I thought it was the right thing to do. It was a smart thing to do. I didn't realize how profoundly important it is. Mm-hmm. I had a man on my team who was African-American. And when I was interviewing people for his job, he was an excellent candidate. But he may not have been the only excellent candidate. I mean, he didn't stand out so far above all the other candidates that it was clear. And I realized it was kind of as one of my old friends used to say, it was kind of a tie. They were kind of, it was a tie. Mm-hmm. And I realized that if it truly was a tie, that's one thing. But what happens too often when it's a tie is you hear this. Well, we got down to 3 good people, and by golly, we got old Harvey, and he's going to be just fine. And that was often code for all the filters I looked through looked like Harvey, right? And so without knowing it at the time and without naming it till 15 years later, I realized that difference has to be a differentiator. If you have a tie, a true tie, you've got to go with difference because your filter is just, it's just pulling you. Your filter's pulling you. And if it's true tie, then you've got to add different people, different things. So as you know, I had an African-American male, an Asian male, I had 2 women, I had an African-American woman, all of it enriched so many things that we did in terms of the conversations. And I never got it right. I never got it perfect. So how are we going to operationalize those 3 priorities? And I had 3 branches to my team. One was create a culture of possibility and positivity out of this forlorn group of people who have given up. That's an overstatement. I picked you and Andy Lum, you for the HR space, Andy Lum for service and general exuberance. Right?
That's right.
That was one branch of the tree. The other branch of the tree was find money. Victor Collymore, Kim Adcock. Victor, get on the contracting, get on utilization. Kim, get on the health plan contracts, the hospital contracts, all these things. Find money, create a new future. And I said, and you guys, leave those guys alone. Because you're going to say, I can save you some money. Get rid of those jobs, right? And I mean, so those were the 2 big branches. And down the middle was Bill Marsh, Mark Zeiderveen, and Andy Wiesenthal. And my message to those, please run the place. Please keep the place afloat while these other 2 branches do the work. Create a new culture, save money, run the place.
Yeah.
So they sent me to Stanford. For me, it was an immersion business class. It was 10 weeks, 8 weeks of business that I never had.
So it was 8 to 10 weeks of business orientation, basically, before you took on the CEO role.
Right, right. So.
Yep. All right. I read something that you wrote, Jack, that said complexity has made specialty care more primary and complexity makes primary care more special. And I thought that was an intriguing juxtaposition of phrases. And what do you mean by that?
So complexity is one of the big vectors that has changed healthcare for the positive and for the negative. And complexity is increased explosion of information, knowledge, technology, IT, from healthcare team 1.0, doctor, patient, nurse. This was the computer. And
for the listeners, I'll just say that when Jack said this was the computer, he was pointing to his forehead.
The physician brain was the computer. So the record was a paper chart, and the computer was the physician's brain. And the team was doctor and nurse and patient. As healthcare became more and more complex, we started to have multiple subspecialists, and we went from x-rays to tomograms. to PET scans, CAT scans, MRIs, an explosion of technology. We went from first generation antibiotics to second generation to third, et cetera. First generation pain pills, chemotherapy, immunotherapy, gene therapy. And all of a sudden, this computer, this human brain, was grossly overrun by that sort of explosion of information. It was just really hard to say what is the right treatment. So we had to have something. And what happened was, especially in the US, we started to specialize and subspecialize. So if you had a cardiomyopathy, you didn't go to the cardiologist. You went to the electrophysiologist or the cardiologist specializing in muscles. We got these people who became more deeply silo-based experts in subspecialty care because of the complexity. So we had cardiologists for the Purkinje fibers and cardiologists for the valves, cardiologists for the vessels, but they were referring patients back and forth. So complexity made specialty care more primary. Where's your diagnosis? We'll send you to that specialist, and that specialist will take care of you. So the first wave of increasing complexity created more subspecialization. And so if you've got a certain type of disease, you went to that disease specialist, and that disease specialist was more or less, at least in private practice, taking care of you. If the cardiologist can't keep up with the cardiologist subspecialization, what's the general internist or family physician going to do?
Wow. Yeah.
So in our country, we started to use more and more subspecialists. And so complexity made subspecialty care more primary. But the complexity continued and we got successful. Mm-hmm. So patients with AIDS survived. Patients with cancer survived. Patients with chronic diseases were living longer. And so now you don't just have cardiomyopathy, you got cardiomyopathy, you've got COPD, you've got a little bump in your creatinine, you're depressed. And so you can't just go from cardiologist to nephrologist to rheumatologist to psychiatrist. And so the second wave of complexity has made primary care more special. Somebody's got to be in the center of the ring with the patient. And no, that primary care doctor doesn't know more cardiology than they used to, more nephrology than they used to, more rheumatology than they used to, more psychiatry, but they know the patient. So the second wave of complexity, which is multi-system disease, people that have more than just one diagnosis, so they've got to go to more places, and successful cures. Cancer patients aren't just dying. AIDS patients aren't just dying. They now get a second and third disease. Somebody's got to take care of that. So the second wave of complexity made primary care more special. Because somebody has got to be there with the patient to make sense of all the craziness, as opposed to the first wave of complexity, which is knowledge, information, deep silos, intellectual arms race. We made specialty care more primary.
Yeah. How do we reconcile that with the reality of a internal medicine physician or a family medicine physician and their work lives and their 20-minute appointments? How do we reconcile these things? And the burden that they have with prior authorizations and data entry?
We have to recognize it. We can't win this by having more and more subspecialization because they don't coordinate care among other physicians well. You can't just say more and more, go to the patients will be going to a subspecialist appointment every day, right? Or every week. And they're in there saying, well, now, if my prednisone is going to help my arthritis, what's it going to do for my kidney, my nephritis? What's going to do that?
And my diabetes.
Right. And so just adding more soldiers in the specialty care world doesn't do it. Primary care has to be reinvented, has to be properly supported, has to be properly compensated.
Okay.
Has to be properly trained and developed. You have to have teams that help you with IT, teams that help you with coordination. It has to be a very different equation, and it's extremely important. I have given talks on 6 continents. Okay, I have not been to Antarctica, and the U.S. is the only place that still debates over whether primary care should be at the center of the healthcare team with the patient. We have made specialty care so primary because of the proliferation of complex knowledge, information, and technologies, and we've forgotten the fact that actually patients need doctors. They need somebody who can see them. I was on a panel one time in Brussels, and on my left was the president of the European Medical Student Association, and on my right was a patient advocate. We were talking about IT and complexity. And I said, so from a patient advocate point of view, what do you think about the explosion of information and how you like to talk to the doctors?
Wow.
And she said, you had your chance. You guys blew it. She said, you guys still think you're the 14th century monks and you've got the tablets. And we're going to go to you to explain the tablets to us. And guess what?
Wow.
Gutenberg ruined that for the monks because all of a sudden he started publishing the tablets and everybody had a tablet. It was called a book. She says, you live in a world where you think we should still go to you for all the information. And I got news for you. It's over. She was obviously very confident and pulling my chain, but she was leading the audience around by the nose. It was so fun to watch. You don't have that control anymore. You still want us to come to you for everything.
Glory be, right? I mean, thank goodness that patients are getting themselves informed and have some potential to check on the information that they're given from whatever source it might be.
Right. So virtuality and virtual care is fine, but it has to be grounded on saying, I know this relationship is trustable. I know this person is trustable. And therefore, it actually becomes quite convenient. We worry about whether the appointment should be 15 minutes or 20 minutes. For the patient, it's 2 hours.
Right.
They got to leave home, leave their job, get childcare, leave their position, drive in, read a 3-year-old People magazine, sit in our waiting rooms, go see the doctor, and then retrace their steps. It's not a 15-minute appointment. Yeah. It's a 2-hour disruption.
It could involve a bus stop in a lot of cases. Yeah. You know, Jack, I'm just thinking of the agony of primary care. And maybe I'm overstating it with that word, considering the privilege that, we as physicians have, but just the disappointment and, burnout is a real disease. It is frightening to consider a burnout rate in medicine at 50%, and it's higher in internal medicine and family medicine. I don't know if you had a chance to listen to the podcast that I did with Jen McCabe-Lance, who was working in a healthcare system in the neck of the woods of your old undergrad alma mater. She just found it unbearable. She didn't see her kids in the morning for years at a time. And she, at one point, jumped ship and started her own direct primary care practice. And now she loves the work she's doing. She's making a living. She's supporting her family. And she's spending the amount of time with patients that patients need for whatever ails them. And what pivot can we take here to get the internists and family medicine docs out of this mode of 15 or 20-minute appointments and prior authorizations and inadequate staff? So they're fetching somebody from the waiting room or, trying to figure out where the fax machine in the building is. What can be done to right this real inequity between the experience of the primary care physicians versus specialties who have the potential for a lot more actual time to use their intellect to serve patients?
Yeah, you are honing in on a precise definition of the problem, which is the most important thing. And once we have the problem in some sense of clarity, then how do we find solutions? I don't have an answer that says, Patty, do it my way.
Doggone it.
So I'm sorry. Part of it's allocation. If you spend $3 trillion on healthcare, why isn't primary care better paid? Why isn't it different? So that's part of it. And, whether it's insurers or hospitals, it's partly an economic issue and partly an allocation of time and resources. No question about that.
Exactly.
And we've been stuck in this codable event as the way we value care. We're codable event, we code for this and it's valuable. So
yes,
if I take off a skin lesion that probably doesn't need to be taken off, I get $150. If I tell people that skin lesion probably doesn't need to be taken off, I get $25. Okay. How do we pay for hip fracture surgery versus say, how do we pay for prevention of hip fracture surgery? It's a $3 trillion business and we're just spending the money wrong. There is a very clear issue here that we're spending the money wrong. So then let's look at work. I recently explained this to a person who works for a large integrated system. They're going to reduce the number of MAs. That's a bold move. We're going to reduce the number of MAs. Let me explain to you my view. In a care situation, you have tasks that need to get done.
Right.
And there are varying levels of complexity and varying levels of time and effort, et cetera. But let's just simplify it and say there are $20 an hour jobs, there are $50 an hour jobs, there are $100 an hour jobs, and there are $200 an hour jobs. If you're smart, what do? You let the $20 an hour job never be fallow. You don't overwork them, but keep them working doing $20 an hour jobs. When they're not there, because you lay them off, you're going to reduce the FTE, that $20 an hour job doesn't go away. Just the $20 an hour worker goes away. So the $20 an hour job has to be done by the $50 an hour person, or even worse, by the $100 an hour person. And then if that nurse and primary care doc, $50 and $100, get overworked, then all of a sudden the $200 an hour person is seeing things that the $100 an hour person could have done if they'd had 20 minutes or 30 minutes. We say we're an integrated system. Well, why do we say we will ever lay off $20 an hour people? Only because we've got less $20 an hour work. Then we lay them off.
Yeah, it was that New York Times editorial by that physician, I think it was Dr. Ofri, where she talked about healthcare and the safety and health of patients is relying on the work ethic and the boundless capacity of physicians and nurses and others. The ever distensible schedule of the physician who is now doing data entry at 8 p.m. at night, sitting on the end of their kid's bed. Jack, what do you think about physician leadership? How does physician leadership in the C-suite, coming back to one of our initial conversations here, how important is that?
I'm trying to find some way to be thoughtfully objective, and I'm having trouble. I think it's essential. I think that the peripheralization of the physician leader, which has gone on from when doctors first left full-time practice to becoming VPMAs or CMOs or something like that, it wasn't wrong. It wasn't bad. They weren't bad people, but they were over here. The COO and the CFO and the CEO are going to do the real work. And we want your opinion, doctor, but you are the CMO. There were some of those people that a little bit of a symbol. They were sort of symbolic more than they were really deeply knowledgeable. So I think
in some ways they filled the bill to meet the demands or the legal requirements
check the box
of the corporate practice of medicine. The CMO in some systems has the responsibility of physicians reporting to that individual, and that sort of covers the basis for legal requirements of a corporate practice of medicine statute. And yet that CMO is reporting to somebody who is not a physician and who has big eyes for bonuses.
Right. I think it's extremely important that physicians continue to accrue other jobs. I don't think physicians are naturally going to become CFOs. That's sort of like a surgeon naturally becoming a radiologist. There is a true discipline there. But as far as COOs and CEOs, line them up, because those jobs are generalist jobs that require teams of experts. And so you don't have to be the expert. Look at me. I never went deep on a lot of things, but I bobbed along with really smart people working with me and working for me and got some results. How could I ever have come to you and say, well, Patty, my experience with HR, we got to change this and that. You go, your experience?
Well, I didn't have any either. So
Right. And so did we fail? No, we succeeded rather swimmingly in important ways. People still don't believe the physician satisfaction surveys, I don't think. And
I still have it emblazoned. We got the phone call from Carl Weiss of Healthcare Research, Inc. on Christmas Eve when the results came in. We had our signature question was, are you able to meet your personal and professional needs as a member of the medical group? And it went from 39%, top two box on the Likert scale, to 57%, 73%, and up to 75% over 3 or 4 years. And that's an enormous increase from 39% to 75%.
You asked the question, how can we fix primary care? My answer is we can. We have the resources. We just have to spend the resources differently, design it differently, do it differently. I gave a talk one time, and it's so funny because you say something outrageous and somebody says, they did that, Jack. I said, why are we talking about medical students having $200,000 worth of debt and we spend $3 trillion a year on healthcare? Let's make medical school free. Here's what I know. everything that's impossible to get done stays there until somebody does it.
Right.
Some guy, some crazy fae from UC Riverside says, we're going to make medical school free. Not for the kids whose dad is an orthopedic surgeon in Newport Beach. No. But we're going to make medical school free for a bunch of kids.
Right.
And their kids that have financial need, go into primary care, practice for 7 years. After that, break a leg. You do whatever you want.
Yeah.
We can make medical school free. We can make primary care work.
Right. I agree.
I am over the hill, but I am not devoid of big fat opinions on that. So I don't know the details about direct primary care. I know that the people who like direct primary care like it a lot.
Mm-hmm.
And if it incorporates an ability to take care of the underserved, financial needs of the underserved,
Mm-hmm.
then why aren't we doing more direct primary care?
Yeah, right. So we started out and you talked about that 21-year-old that fills out a medical school application, writes an essay, and is a 21-year-old idealist. And I wonder if you were going to go back and share something with your 21-year-old idealist self, what would you want that person to know?
Be very, very careful when people tell you what cannot be done. Be very, very suspect of advice that tells you exactly why things can't get done or won't get done or are impossible. You have a pluripotential professional preparation and the world is your oyster. You may want to say, I'm going to take my medical degree and spend my entire energy on climate change. Because you need a good physician in there who's got some chutzpah, and chutzpah is gender neutral, right?
Yes.
Okay. I worry about using a word, and I think, does that apply to men or does that apply to women? Or you can see 30 patients in a day in a primary care office. I mean, they're both honorable pathways.
So these are just a couple of quick hitters, but what are you most proud of when you look back?
That I stuck my neck out.
Ooh, I love that. Absolutely.
I had plenty of opportunities to not do what I did. I'm going to start crying. I had plenty of opportunities to not do what I did. And I did it.
Sticking your neck out. What a message. There's a message of hope. And any regrets?
Sticking my neck out too far. Getting to the point where I didn't realize that there were certain things that I just couldn't overcome.
Mm-hmm.
And I still tried to overcome them.
Interesting. And I don't know if this is my last question. Often I promise that and then it isn't. But what would you say is the most transformative period of your career so far?
The time I spent with you and Hergot, those human beings. When I took that on and I found out that you and Lum and Hergot and all those people, I didn't have any ability to appreciate it at the time, but that was truly magical. And that was amazing.
Mm-hmm.
Talking about big changes, private practice, starting a new system and changing careers and changing specialties and
transitions.
Because I was so out of my sweet spot. And I didn't take the time to do the MBA. I'm not trying to be catty, but the MBA and the MPH and the PhD, they're all good, but the MD is enough. The MD is enough to make you a person of substance beyond the exam room. Mm-hmm. Don't forget, those people can't come in the exam room. But you don't say the IT people are a bunch of geeks on the third floor or the finance people are a bunch of suits on the second floor. You say, they're coming to work every day trying to fix healthcare. And if I let them work in silos, they're probably not going to get the nuance and the sensibility and the patient advocacy filters that they need. But they're still going to come to work. They're still going to get paid, and they're still going to try to create solutions. So that transition was amazing. I mean, if it hadn't been me, I would have been amazed by me. I mean, Patty and Andy change the culture, work on service, give me all these big cultural changing mammoth jobs. Save money, find money, and leave them alone. And you three, please keep this thing afloat for a while because I've got a lot to learn. And that's actually what I thought.
Right. And what you said at the time. I mean, you framed it that way. That was the most engaging team getting things done.
And it wasn't like we couldn't do anything wrong, but it was just so energizing to do what was right.
All right. Well, we should say our goodbyes. Okay. So Dr. Cochran, thank you so much for coming on to the License to Lead podcast. And it's always just a blast to talk with you.
Just one word I take away: exhilaration. Thank you.
Appreciate it. Bye-bye.
All right. See ya.
Thanks for listening to the License to Lead podcast. Be sure to visit licensedtoleadpodcast.com to join the conversation, access the show notes, and sign up for our newsletter. Leave us a message with your provocative question or your thoughtful comments. You might inspire a future episode of the License to Lead podcast. Thanks so much, everyone.